Hi guys.
Hello, Akansha. Everybody, good morning.
Hi.
Good morning, Dr. Kancha.
Hi Anju, how are you? You sound a little stuffed.
4 days because of infection. No, I was very sick because of the duty.
Because of COVID duty?
Yeah. Many people came positive now. So again they put me in the quarantine and all. So that's why I was not able to come in 4 days. I was very sick. I was just listening, trying.
Yeah, I hope you feel better.
Yeah, it was actually the cases came down in India, but suddenly they are rising again.
I know, yes, and that's so much like it's concerning.
Yeah. I hope everything okay.
All right. I guess we can start. We have Nidhi, we have Monica. We have enough people. Okay, let's get started. So today is the last session of our Zoom meeting. Say again. I'll mute everyone. You can unmute yourself when needed. So yeah, today is the last session of our Zoom meeting, and we will be coming to an end for our flow cytometry course, which is sad, but we learned a lot, and I will try to figure out if I can see who attends the YouTube sessions or maybe the sessions that are in our website. If I can figure that out, then maybe I can give out more certificates. We'll see. All right, we have 17 people. We can get started. So who wants to attempt this flow?
I can try this.
Go ahead.
Okay. So in the CD45 versus side scatter, in the green, we have grands, blue limbs, pink monos, and then we have this orangish brownish population, kind of in the blast gate going down, like with dim to no CD45 and dim side scatter. So basically some blastic population.
Mm-hmm.
Then CD30, these cells are negative for 34 and 117.
Mm-hmm.
Then they are negative for glycophorin and showed it is CD4, like dim or dim CD4.
Partial positive for
Yeah.
CD4. Yeah. Mm-hmm.
Okay, negative for 13 and 33.
Mm-hmm.
Then they're positive for 71 and 61.
Mm-hmm.
Then they're again positive for 41 and dim positivity for CD4. So
Right.
basically in the blast gate population, positive for CD41, 61, 71, and dim CD4 positivity. So increased like blast cells with all this, and they come in the megakaryocytic lineage.
Right. So it's a straightforward case. This case, so acute megakaryocytic leukemia, it can be either 122, and that's what this was. This was acute myeloid leukemia with translocation 122. And those are more of megakaryocytic types, and also those associated with Down syndrome or transient abnormal myelopoiesis that also happens in Down syndrome. Those can also be megakaryocytic type. They will also be megakaryocytic type, but one thing to remember, if you are going to call it AML with translocation 122, you have to make sure that the patient does not have Down syndrome. And if the patient has Down syndrome, you cannot call it this entity. So this is something that you have to remember. By definition, you cannot. So let's see what scenario they are giving us. 6 months old, So again, this is a age range 6 months that you would think like the neonate is the age range for TAM, like 6 months, one year you start getting the AML with downs, but here there is no evidence of downs. So previously healthy female presents to pediatrician, irritability, fatigue, poor appetite, enlarged spleen and liver, hematocrit of 12, very low, and normal platelet and WBC count. And a review reveals 30% unclassified cells, which includes the blasts that range from intermediate to the large size to large size, and deeply basophilic and cytoplasmic blebs. So I think I showed you the megakaryocytic blasts in one of our ACE sessions, and those cytoplasmic blebs and basophilic cytoplasm, it's kind of typical of megakaryocytoblasts. Bone marrow examination is performed, and aspirate is hemodilute, so a portion of core biopsy. Okay, so then Nidhi very well summarized this. So because the patient has a dry tap, the portion of core biopsy is disaggregated. So over here, they disaggregated the core biopsy and submitted for flow cytometry. That's very interesting. Flow cytometry demonstrates an expanded population in the blast gate, and decreased CD45, low CD4, and 41, 61, and 71. Abnormal population is not expressing 1333, is not expressing B and T cell markers, and glycophorin A. The findings are consistent with acute megakaryocytic leukemia, and FISH had 122. So acute megakaryocytic or acute myeloid leukemia M7 is a subtype of AML. So here is the definition: 50% or greater blast have megakaryocytic differentiation. This subtype of AML is uncommon overall, but is seen in increased frequency with Down syndrome and in association with 122 translocation. According to using the WHO 2008, classification of AMKL is dependent on genetics, with cases associated with characteristic genetic change including 122, trisomy 21, or inversion 3. So inversion 3 can also be megakaryocytic. And subclassified by genetics and remaining cases falling under the subheading AML, not otherwise specified. The AML 122 is seen primarily in infants associated with organomegaly and similar morphologic and immunophenotypic findings as the NOS category. And AMKL, that is seen in Down syndrome, will be discussed later. So AMKL blasts range from intermediate size with scanned cytoplasm to large with basophilic cytoplasm and cytoplasmic blebs. The marrow is typically fibrotic, so that's a usual phenomena with the megakaryocytic AMKL, that the marrow will be fibrotic, leading to some cases to hemodilute aspirate. Although morphology and clinical settings may suggest megakaryocytic differentiation, additional studies are required to demonstrate megakaryocytic differentiation. Lineage assessment was previously achieved by the methods including platelet peroxidase evaluation, but is now performed almost exclusively by flow cytometry. Flow cytometry is critical not only in determining the blast show megakaryocytic differentiation, but also in differentiation of this subtype of AML from other types, from the subtypes of acute leukemia, and from non-hematopoietic neoplasms. So blast of AMKL typically show expression of megakaryocytic markers, including CD41 and CD61. So CD41 being glycoprotein 2B and CD61 being 3A. Both markers are typically present on the cell surface. However, some studies show intracellular CD61 may be more sensitive marker, and we discussed that in our AMKL session in the cases that intracellular CD61 they do in many institutes, in some institutes at least. CD42 may be occasionally be present, but later in the maturation on platelets. So that also we discussed that CD42 is more of a mature marker. It will be seen in platelets and is therefore not often expressed on the blasts of AMKL. So 41 and 61 are the blasts, 42 is more of platelets, and intracellular 61 is more sensitive. CD36 is typically positive, but it's not specific as this marker is expressed in the monocytic and erythroid leukemias. CD45 variable may be absent, and variable expression 13, 33, 34 HLA-DR, and 71. With these, so 71 as well, it's the erythroid marker, it's also there. And also the myeloid variable expression 1333 can be there, the stem cell 34 and HLA-DR has been reported. And myeloid or monocytic markers, including MPO 16, 14, and 64 will be typically absent. So my MPO and then more mature 16 myeloid marker, and then 14 and 64 will be absent, and as are lymphoid markers, but CD7 can be present. So as for the exception of CD7, which may be aberrantly expressed. And flow cytometry of AMKL requires consideration of several technical difficulties. As noted, the patients typically present with marrow fibrosis and dry tap. Therefore, flow cytometry of a portion of fresh bone marrow biopsy may be considered to enrich for neoplastic cells. Also, markers used to signify megakaryocytic differentiation, including 41 and 61, are expressed on platelet that can adhere to the blast or other cells, leading to false positive. So we all, Raji had a very trick case that had platelets that were adhering, and that gave the false positive result. And therefore, repeated washing of the sample prior to labeling to release adherent platelets is helpful when evaluating these markers. An alternative approach to use is either 41 or 61 in conjunction with 42 to identification of the adherent or mature platelets. So that's a nice cute chapter. So AMKL is an uncommon subtype of AML overall, but is seen in increased frequency in children with Down syndrome. In addition, AMKL is associated with 22, and the patients will have organomegaly. AMKL is associated with marrow fibrosis, dry tap, markers 4161, and adherent platelets. So make sure that you are doing either intracytoplasmic 61 or CD42 and washing the specimen. So it's a nice, cute chapter. I think we don't need to summarize this. It's like very straightforward chapter, easy chapter. You want to summarize in a minute, Nidhi?
Sure.
Okay.
Okay. So acute megakaryocytic leukemia, basically it's an acute leukemia with more than 20% blasts, of which more than 50% are megakaryocytic lineage. Then to call it like AM, there can be 3 genetic abnormalities which should be ruled out, either associated with Down syndrome, translocation 122, or inversion 3. If any of these is present, then it will go into that category. And if Down is present, then it just goes into that. If not, then it comes as a acute megakaryocytic NOS. Then quickly coming to the markers. So we have 41, which is 2B, 61, which is 3A. Usually these are expressed on cell surface, and that's how they are usually done. But some institutes do like intracellular CD61, which is pretty specific. Then we have CD40. So then there is a marker CD42, which is basically glycoprotein 1B, and it is a marker of maturation, and it is present on mature platelets. Then we have CD36, which can also be present, but it is not specific. Then it's a CD45. I think that's important to, like, as in even we were seeing in this flow, the CD45 was variable to absent. So that's another clue, because usually blasts are like dim CD45, but here they were in that range. Then they are negative for myeloid and lymphoid, except CD7, which can be present as an aberrancy. Then important point, which we even saw in our cases.
So before you go into others, so 1333, like the others that these can be present in the myeloid blast as well, they are positive, like they are variably positive, and there can be like positivity in those. So not all the myeloid antigens are negative, or more of the mature monocytic and the MPO and the mature granulocytic, they are absent. And 34 usually absent in megakaryocytic lineage, but they are saying variably present. And HLA-DR, and 71 is another one that you have to remember, that AMKL expresses 71 very often.
Okay. Then, so yeah, that's even we were seeing the 71 positivity in our case. So yeah, that's a good point to remember. Then platelet, sometimes platelets can adhere to any blast and can give like a false picture that it's megakaryocytic in those, because there would be false positivity of 41 and 61. In those cases, either like repeated washing or doing CD41 and 61 in conjunction with CD42 would be helpful.
Okay, perfect. Okay, so let's go ahead. Anyone wants to attempt this one? Let's see who are. Okay, go ahead.
If someone else to try, they can. Otherwise, I'll just give it a blind try. Okay, again, in 45 versus side scatter, we have grans, limbs, very small monos in pink, and then blast population in reddish orange. Then those blasts are CD34 positive and CD38 positive, kind of like some are kind of losing 34.
Mhm.
Then they are CD33 positive and then 13 negative. Mostly it's 33 is like a blob, small amount is like dim 33. Then they are, I'll say HLA-DR positive and like CD4 positive too. Some mostly are like dim HLA-DR, and a small
Dim.
subset is some small
Yeah.
subset is like
Yeah.
comparatively bright.
Yeah.
And then like they are showing CD4 positivity too. They are CD7 positive, and the small subset is CD56 positive as well.
Mhm.
Then CD117 positive, and a small set is 41 positive.
Mhm.
Then CD61 subset is 61 positive. Then this is normal maturation. Is this peripheral blood? So we should not be seeing this like this. So they're basically a left shift of the myeloid cells.
Right. Perfect. So with the history of Down syndrome and a 3-day-old newborn, what would you think of this one?
Transient abnormal myelopoiesis.
Yes. So 3-day-old Down syndrome came to ICU with pneumonia, persistent elevated WBC, left shifted myeloid maturation, hematocrit and platelet counts are both normal. So do you described correctly? We have like subset that is 41 positive, subset that is 61 positive. This is also a case of with a left shift. So this is also a case of megakaryocytic differentiation with the 41 and 61. So flow cytometry expanded population of myeloid blast present in the context of left shifted myeloid maturation. The 34 blast were 13.6 of the WBC. And then expresses 33, 38, and 117. With aberrant loss of 13 and HLA-DR, so with loss of HLA-DR in majority of them. Blast express low levels of 4 and CD7 that is uniform intermediate and CD56 on some minor subset. The blast expresses 4161 on the subset, and immunophenotype in context of the clinical settings is consistent with the TAM. So TAM of Down syndrome. Down syndrome is associated with increased incidence of acute leukemia that is most pronounced during early childhood but presents into adulthood. Persist into adulthood. Usually the Down syndrome will be like the TAM will be early on and the AML of Downs will be later. So this is something that we can remember. In contrast to children with Downs, in whom acute lymphoblastic leukemia is most common, children with Downs have similar likelihood of AML or ALL within first 4 years of life. With respect to AML, the most common subtype seen will be AMKL, which accounts for 70% of the AML seen in children with Down syndrome who develop AML under the age of 4 years. Of interest, approximately 10% of the newborns with Down syndrome will develop a TAM characterized by increase in abnormal blasts of morphologic immunophenotypic features of megakaryoblast. The blast percentage may exceed. This is very important point. So if you have newborn, like you can have like similar history that it is a 3-day-old newborn, maybe like less than 1 month old newborn, and you have a blast count that is more than 20. I remember when we were reading WHO book club, and one of the persons, like one of the pathologists who was attending, he had a case, and that time he messaged me as I'm seeing some blasts, that this is a newborn child, and I'm seeing some blast, and he said that it is more than 20%, and I'm thinking whether I should classify it as transient abnormal myelopoiesis or acute myeloid leukemia. So it's something that we have to remember, that in those early stages, like less than 1 month old, with Down syndrome, the TAM is the one that you have to classify. even if it exceeds more than 20%. And what you have to do is you have to follow up these patients, because most of these patients, like many of these patients, I should not say most, because most of these patients resolve spontaneously, but many of these patients, they do progress to AML in the later stages. And if you consistently observe this patient and the patient has not reduced his blast count, then you are going to classify that as AML. So that's the point that you have to remember. So blast percentage may exceed 20% and may be accompanied by leukocytosis and thrombocytopenia. Median age at diagnosis of TAM during first week. So this is the typical, like it will be presenting in first week of life, can be present at utero, leading to hydrops fetalis as well. Most cases are diagnosed in the age of 2 months. Blast in TAM resemble those of AMKL in Down syndrome, morphology, and immunophenotype. Of note, TAM is associated with spontaneous remission. So most, like 80% or 70 to 80%, will be having spontaneous remission, and only 22 to 30% of the cases will be progressing to AMKL, which will develop in early childhood between 1 to 3 years of age. So basically, you have to like follow up them. And if they persist beyond 3 months, 6 months, then you have to start thinking of AML. The blast of TAM and AMKL of Down syndrome have a similar immunophenotype by flow cytometry. The blast in TAM, so basically will be expressing 34, 38, 56, 117, 33. And CD7 aberrantly expressed, CD4 aberrantly expressed, 41, 42, 36, 61. So over here, they are also expressing 42 as well. And then,
Can I ask a question?
yes, please go ahead.
Is there any threshold for TAM that if it exceeds, it goes into acute myeloid leukemia, or there isn't any?
To my understanding, if you have a newborn that have megakaryocytic blasts that are even, like there is no threshold that you are going to call it AML. There can be many blasts and you are still going to not label it as acute myeloid leukemia. You're going to label it as transient acute myelopoiesis, abnormal myelopoiesis. And you're going to follow up that patient, see for 2 weeks, see how the patient is doing. And eventually you're going to label it as acute myeloid leukemia, but not the initial phases like few days after birth.
Okay, there was a case in which the baby was 2 days old and
Yeah.
he had 84% blast and the
Right.
platelets were suppressed as well.
Right. Yeah,
So
I know. Those cases are hard. So go ahead. You were asking something.
This was my question. Thank you.
Yeah, I know. Like there can be very high blast in case of TAM. And to my understanding and to my knowledge, I don't think that there is any cutoff for TAM to call it AML. And the only thing that you have to do is you have to monitor that patient. And if the blast count are coming down, it will come down. It will be spontaneously there will be spontaneous remission. Then if it is spontaneously remitting, then you know that it is not AML. But if it is not remitting and it is continuing beyond 3-6 months of age, then you are going to label it as AML of Downs.
Thank you.
Yeah.
Yeah, I agree with that, because we also advise to follow up clinically and see whether it undergoes resolution on its own or it progresses to leukemia.
Right, exactly.
That is
Yeah, that is a very important one, because you get these cases like these are rare cases, and so one of the times, maybe a couple of times in your life, you'll see these cases and you have no clue what to label these cases as. So this small trivial thing is important to remember, that if you have a newborn, then don't directly label it as an AML, despite if it is more than 20%. Anyone has anything to add, their experiences or anything?
Like I saw one similar case in which blast was high, like not like 80, it was I think 40 or something, and we ended up calling it TAM.
Right. Yeah. Okay, so we were reading 34, 38, 56, 117, 33, 7 aberrant, 4 aberrant, 41, 42, 36, 61. So megakaryocytic, and 71 here as well. CD13 will be often negative. So we saw that 13 was positive in those cases of A122. Like it was variable. Over here, it's clearly negative. 11B is clearly negative. HLA-DR was variable over there. Here it is clearly negative. Expressed in approximately 30%. So here as well, it's variable. Blasts are negative for 14, 16, MPO, and glycophorin. So similar to 122. And in AMKL of Downs, the blast immunophenotype is similar to DAM, exactly. However, AMKS of Downs, blast are more frequently will be negative for 34, 56 HLA-DR. So AMKL of Downs, blast are negative for 34, 56 HLA-DR, and can be positive for 11B and 13. So that's something that we can read when we have this case in our life. Of note, TAM and AMKL of Down syndrome may be indistinguishable on the basis of morphology and flow cytometry, with TAM sometimes associated with blast percentages exceeding 20% in the blood. The blast percentage is often higher in the blood than in the marrow. These entities are distinguished on the clinical grounds, with AMKL typically occurring after the first year of life. So that's what we were saying, that you have to follow up these patients, and if it persists, and then TAM is usually 2 months of life, and even not 2 months, like most cases of TAM you will see within 1 or 2 weeks of birth. So that's something that you have to remember. Cytogenetics may provide a clue, as TAM is not associated with any cytogenetic changes except for trisomy 21, while AMKL of Downs will show additional cytogenetic changes, usually numeric abnormalities. Unlike AMKL, not associated with Down syndrome, both TAM and AMKL of Downs are associated with GATA1. That's important one. So GATA1 mutations are seen very frequently in these TAM and AMKL of Downs. So transient abnormal myelopoiesis is a transient myeloproliferation seen in infants with Down syndrome that may resemble AMKL by morphology and immunophenotyping. Distinguishing these entities relies on careful clinical correlation. Children with Down syndrome have an increased incidence of acute leukemia, with AML being as commonly diagnosed as ALL. Most frequent AML will be AMKL. Children with TAM has increased incidence of AMKL in the early childhood. So that's that. Anyone has any questions or anything to add? Anything that they would like to say? Okay.
Whatever cases we have seen, mostly they undergo resolution only, like when they are followed up.
Right.
Most of them.
Right. Yeah. That's the most important thing. That's why we don't call it AML right outset. Right. How many cases have you seen, Dr. Gupta?
Maybe 5, 6.
That's nice. Very good. Yeah.
And immunophenotypically, they are all same. Like they also say, in most of the cases, when it comes to an individual case, you can't differentiate based on the IPT.
Right. Yeah.
Immunophenotype for TAM
and the Downs. Yeah. They gave us some changes over here, but again, like the most important markers will always be there: 41, 61, 42, and the others. Okay, Nidhi, ready to summarize? Just quick summarization. Are you still here? Oh. Anyone else want to summarize? Did they write some points, or I can summarize maybe?
Sure, I'm back. Sorry, I
you-
just got pulled over.
Yeah.
Okay, so TAM. We read from here, and then I was also like just reading WHO on the side so that if we can get anything. So TAM, basically, it's a disorder of newborns with Down syndrome that presents with clinical and morphological findings indistinguishable from AML. And basically, the blasts usually have megakaryocytic lineage. It's associated with Down syndrome, or for the mutation sake, we read that acquired GATA1 mutations. Then how is it usually diagnosed? It is usually diagnosed at age 3 to 7 days. Then when we see in those patients usually presents with leukocytosis and thrombocytopenia. There's usually marked leukocytosis and thrombocytopenia. An important point, as we did in Brent Wood too, the percentage of blasts is higher in the peripheral blood, and they may even exceed the percentage of blasts in the bone marrow. Often patients have hepatosplenomegaly too. They usually undergo spontaneous remission in first 3 months of life. However, a few children can experience life-threatening complications, and the complications can include skin rash, cardiopulmonary failure, splenic necrosis, renal failure, hydrops and or in 20 to 30% cases, they can like progress to AML at 1 to 3 years of life. Okay, then coming to they have like megakaryocytic blasts. Then I think WHO summarizes blast immunophenotype like pretty well. They say in TAM, they are positive for CD34, the blast, CD117. So basically, so 41, 42, and 61 positive. That's megakaryocytic lineage. But other than that, like they are also positive for 34 and 117, which are immature markers. Then they are for the myeloid, they are positive for 13 and 33. Then it's saying they're positive for HLA-DR2. Then for lymphoid, they show like dim CD4 expression with aberrant expression of CD7 and 56. So that was for TAM. Then for differentiating, we were reading that to differentiate it from myeloid leukemia associated with Down syndrome. So they say that the myeloid leukemia associated with Down syndrome immunophenotype is pretty much similar to TAM. WHO says two differences in these, that TAM blasts were CD34 positive, but here they are saying that with blasts associated with Down syndrome, CD34 is negative in 50% of the cases, and also 30% of the cases are negative for CD56 and 41. So 41 is also like negative in 30% cases associated with Down syndrome. I think that should be kept in mind. And pretty much else, there's like everything else is similar.
Perfect. All right, great. All right. So if no one has any other comments, we can go ahead. All right, who wants to take this? I'm gonna do, this is like typical case if someone wants to do it.
Should I take it then?
Yeah, go ahead.
Okay. So we have limbs and then we have blasts with dim to absent CD45 and low side scatter. Then those blasts are positive for 34 and 19. They are positive for CD10, and then a subset is positive for 20 as well. Then again, they're positive for CD10 and negative for CD38.
Okay, what do you think of these blasts?
So lymphoid blast, B lymphoblastic.
Yes, so that's what it is, a straightforward case of BALL. So I think like we did not read the BALL and TALL at the time that we were doing those BALLs and DALLs. I think that we did not read, so I'm reading it again, if at all we read it again too. So again, 3-year-old boy, fatigue, poor appetite, bruising, WBC 70,000, and anemia, thrombocytopenia. So flow cytometry of peripheral blood demonstrating population of blast with low to absent 45, expressing 19, 34, bright 10, variable 20 without 38. Findings are diagnostic of BALL. So BALL is the neoplasm of blast committed to B cell lineage and is typically seen in marrow and blood, but can involve the tissues as well. Primarily a disease of childhood, majority of the cases occurring under the age of 6 years. And flow cytometry will play a critical role in the diagnosis. Also, minimal residual disease testing by flow cytometry is significant marker of prognosis. So that's what they will come to later, I guess. Blast in BALL typically will express B cell markers. So 19, cytoplasmic CD22, dim and membranous, and cytoplasmic CD79A. And TDT is commonly expressed, as is CD10. And so 98% of the cases, the TDT will be there, and CD10 will be 86% of the cases. 34 will be present in 77%. 20 will be present in the subset in 45% of the cases. So that's that. And They sometimes ask us, like, when we report our cases, they want to know if CD20 is positive for therapeutic purposes. And sometimes they even ask what percentage of cells are CD20 positive. So that's something that's important. Trivial is that some of the BALLs will be TDT negative, CD34 negative, and sometimes they can be CD10 negative as well. So those are the small, like, number of cases that that are more mature, kind of immature, if that makes sense, more mature stages of the immature blasts. That if you remember, we had in our early sessions that they lose those markers, and that should be kept in mind. And CD20, majority of the cases, it should be negative. It's a more of the mature marker. But again, in those later on cases, the CD20 is expressed, and when present, it is present only in a subset of cases of the cells. So when present, 20 expression will be weak and variable. Myeloid markers expression. So myeloid markers will be seen in BLL, and can be seen in BLL, 13 in 28% to 55% of the cases, 33 and up to 43% of the cases. And rare cases, there can be 117 as well, less than 1% overall. So it's small, very small cases, like number of cases that can have 117. MPO. So there should absolutely be no MPO, because these cases, in sometimes, like, there is 19, there is no 10, there is no TDT, there is 10 will be most commonly present, TDT very common, like most commonly present. But if there are not there, then you have 19 and you are thinking whether it is of any other lineage too, because there can be, as we saw, there can be 19 expression in case of myeloid cases too, as in 821. So expression of MPO is something that is going to help you that time, and MPO is more of the lineage specific anyways. So that will be arguing against the diagnosis of BLL and raising the possibility of MPAL. And T antigen expression is infrequent in BLL and has been reported. Expression of markers including 4, 7, 5, and 2 has been described. Many of the markers above are expressed on normal B cell precursors. Several authors have outlined the typical pattern of antigen expression seen with maturation of the cells has progressed from undifferentiated blasts to normal B cell precursors to or hematogons to mature B cells. The abnormal blast in BALL can be typically differentiated from normal hematogons because abnormal blasts deviate from the normal differentiation pathways. An ideal panel for differentiating normal and abnormal blasts should be include the markers of with varying intensity of B cell maturation. So we saw the case of hematogons in our nutshell. If you want, I can review it again. But all these markers 10, 19, 20, 34, 85, 38, and 45, those are variable in case of when the maturation happens. And that 10:20 graph is kind of the waterfall graph, is kind of very, very classic that many of the people like to see. And even the others, there's a set of maturation patterns that happen with hematogones. So that and then as compared to the BALL will be more of a blob with aberrant very high or very low positivity of the antigens, and it will be sitting somewhere. So it will not be having that variable kind of expression that will be seen in the maturing hematogones. So commonly reported antigenic aberrancies fall into categories including antigen overexpression or underexpression, asynchronous expression of the antigens, and presence of abnormal spectrum of the antigen expression. Aberrant expression of one or more antigens is seen in nearly all cases of BLL evaluated when using an adequate antibody panel. These differences are particularly helpful in identifying minimal residual disease. Differentiation of normal hematogones from abnormal B lymphoid blast is critical, as the former is commonly observed in samples of post-therapy BLL. Other markers helpful in distinguishing from normal to abnormal include CD9, which shows abnormal uniform expression on the abnormal blast, CD81, which is aberrantly underexpressed in BALL, CD49F, which appears to be overexpressed in BLL, and CD123, which shows concordance with CD34 expression in 90% of the BLL. in contrast to the discordant pattern expression of these two antigens in the hematogons. So these 4 points you have to remember for MRD, like MRD. So when you are distinguishing your post-therapy cases from hematogones to BALLs, so again revising this, CD9, abnormal uniform expression on abnormal blast, CD81 underexpressed, then 49F overexpressed, and 123 will be concordant to 34 as compared to discordant in case of hematogones. So MRD they have shown over here, nice. So this waterfall pattern that I was talking about, and we have spoken about that in our BLL sessions and also in our earlier sessions with ACE and so forth. So this kind of first, it will be CD10 positive over here, and then as soon as it starts losing CD10 and eventually like these maturing hematogones, they keep on acquiring 20 and and then with bright CD20 and loss of CD10 are your mature forms. And this case, they are showing a case of BALL in the bottom and a case of MRD in the top. So they are showing the maturing hematogones in this light blue and dark blue, and you can see the nice pattern of variability of expression. However, in this one, you can see that this pattern, these hematogones have different different markers as compared to what the BALL had. And actually the residual disease or minimal residual disease is having similar antigenic expression as compared to your BALL. And you can see that your BALL was 34 positive. This is also 34 positive. This is 38 negative, both of them. And then this was 10 positive in early on cases in the first diagnostic case, and it's also 10 positive. Most of the subset was 20 negative, and most of the subset that remained was 20 negative, and similarly 10 positive and 38 negative. So minimal residual disease panel shows 19 positive B cells from marrow collected at the day of 28 post-induction for the MRD evaluation. And showing this first patient's blast at diagnosis for comparison. Mature B cells are shown in dark blue, and the hematogones are shown in aqua. Normal immunophenotypic changes seen in B cell development are indicated by the arrow. In addition to normal background B cells is a population of highlighted that is in red that represents only 0.2% of the white blood cells and expresses bright, I should not say 0.2 because that's significant in case of MRD too. Expresses bright CD10, 34, low to absent 20, and without 38. This abnormal blast differ in immunophenotype from normal background hematogones and mature B cells and show an immunophenotype similar to blast seen in the patient at diagnosis. So certain genetic abnormalities are seen in BLL. So we, let me quickly open my drive. What happened? Oh, it's because I am in Yahoo. Okay, I have to go in Google. Why is this Yahoo? My drive. So let's go back here. All right, so these, let me quickly show you the hematogones pattern. Actually, I was going to show you something else. I forgot what I was going to show. It will come to me. Yeah, I was going to show you this. I remember now. So BALL, not here. This. So BALL has this recurrent genetic abnormalities that like that is a separate category of BALL. And I wish, let me enlarge this a little so that you can see it well. So there are certain features of this recurrent genetic abnormalities that you have to keep in mind. And if I can. Here. Okay, so these typical recurrent genetic abnormalities, and some of the important things that you have to remember in these genetic abnormalities is the KMT2A or MLL1 that has 11q translocation. This one is CD10 negative. And another thing that you have to remember is CSPG4. That is kind of specific for this, and that is seen in KMT2A rearrangements. And then another important point is the 119 TCF3 and PBX1. Those are CD34 negative. So that's something you have to remember. And another thing that is important in this one is that the BALL with BCR-ABL like, these will be having CRLF2. So that's something that is an important one for the 922 or BCR-ABL like. And the BCR-ABL 922 really, that will be having those myeloid antigens more often, 9, 13, 33, 25, and 66C. So those, and then the 514 one, that the one that with eosinophilia, that is the one that has eosinophilia. So that's an important point that you have to remember here as well. And IMP21 is more of low TLC versus KMT2A is more of high TLC. So that is kind of some important points that you should keep in mind amongst those recurrent genetic abnormalities. And I'll not go into a lot of theory, but the CRLF2 that is in BCR-ABL like, not in the BCR-ABL, but BCR-ABL like of BALLs, they have a poorer prognosis, and the worst prognosis of everything is the 922. The BCR-ABL has a worst prognosis. So BCR-ABL and BCR-ABL like, they are the poor prognosis cases. And this one, BLL with hyperdiploidy. So not the hypodiploidy, BLL with hyperdiploidy is a favorable prognosis. So very favorable actually. So these are small points that you have to remember about this, and they might come to one of the cases that will maybe have that feature. So yeah, that's what I wanted to show there. And translocation 922 occurs in approximately 25% of the adults with BALL. The presence of this chromosomal abnormality is frequently associated with myeloid antigen co-expression. So that's what we showed in our table as well in the ACE. So myeloid antigen frequently 13, 33 will be there. And translocation 1221 is seen in approximately 25% of the cases and is also associated frequently with the myeloid antigen expression. And 56 can be noted in subset of the cases. With this cytogenetic abnormality. BALL with MLL 11q23 is associated with decreased or absent CD10. So that's what we showed. Decreased or absent CD10 with expression of CD15. This immunophenotype is most commonly seen in patient with 411 or MLL1 phenotype. So 411 translocation. And finally, loss of CD34 may be seen in BLL with 119 translocation. So those are the important findings. I mean, you will mention them in your flow reports, but you're not going to mention those particular translocations for obvious reasons. But those are just associations. You can, that's a trivial, like that's a trivia. You can tell the clinicians. Sometimes the clinicians would ask, oh, this is CD10 negative, or oh, like how are you doing it? Like there was a case where one of our clinicians, he asked similar question. Okay, it is TDT negative, it is CD10 negative. Then how are you saying that it is BALL? And we had to explain that some of the cases can be like that, and it's not a mandatory. You have CD19, that's the lineage specific marker in there already. So CD19 over here, they have showing a CD10 negative case that has the MLL 11q23 rearrangement. So this CD10 negative with CD19 bright, and over here again CD19 present, and I mean over here it looks more brighter, and then CD15 is there. So as they said, that decreased or absent 10 with the expression of CD15. And then they are 34 negative, and CD33 negative as well. So that this is more of the 11q23 gene rearrangement. And this one had a positivity for TDT, and these 11q usually are positive for TDT. So that was not shown. And they are negative for CD10 or 34, CD15 low positive, but other myeloid antigens are expressed. So MRD, detection of MRD is an important prognostic factor for both pediatric and adult ALLs, and with clinical significance imparted to early blast clearance daily, day 8 to 19. MRD at the end of induction and MRD post consolidation. So all of these are important, to quantify the MRD at those times. So this is an important, very important point. A level of more than 0.01 abnormal blast has been established to have clinical significance in most of the studies. And MRD appears to be continuous variable with higher levels imparting a poor prognosis. So even like it has poorer prognosis as the MRD increases. So more than 0.01. In study conducted by Children's Oncology Group, the MRD at the day 29 induction emerged as the most important prognostic factor impacting the outcome in the large cohort of the patients with pediatric ALL. MRD assessment by flow cytometry, a sensitivity of less than 0.01 for optimal requires a sensitivity of less than 0.01 for optimal prognostication. In order to achieve a high sensitivity, you have to have at least 500,000 events, and allowing the assessment of 4 or greater parameters simultaneously will be suggested. So you have to assess 4 or more parameters to, and then we already saw the parameters that we need to assess. One important consideration in evaluating patients with MRD is the observation that phenotypic shifts are common in ALL post-therapy. Blast population may shift the intensity of antigen expression with therapy or at relapse. Therefore, investigations of MRD should not be limited to identifying the exact population seen at the diagnosis, but should include evaluation of the population that differs in the immunophenotype from normal hematogones. So the immunophenotype can shift and just not, it might not be the same. So any population that is differing from the normal hematogones should be considered as well. So B lymphoblastic leukemia lymphoma is neoplasm of blast committed to B lineage, in which flow cytometry plays a critical role in diagnosis and assessing prognosis. Some correlates have been described between genotype and immunophenotype of B-ALL. Detection of MRD post-therapy is an important prognostic value. Okay. Anyone to add something before we go for summarization? Any questions?
Just
So
want to add
Akanksha,
one point, like,
Go ahead, Dr. Gupta.
yeah, so you mentioned CS PG4 in addition to CD15, which is done in CD10 negative cases.
Right.
So we do it by the name of NG2, the neural glial protein. So they are same basically,
Got
CSG2,
it. Yeah,
CSPG4 and NG2.
Right.
They are the synonyms basically. So
Yeah,
we do
right.
it by the name
That's
of
correct.
NG2.
We mentioned that in our theory part, but we didn't mention in this table, NG2, yes.
Akanksha, the presence of MRD indicates poor prognosis, is that right?
That's correct. It
Then what do
indicates,
we do in this cases?
so they will increase their induction consolidation, like they will modify their treatment plan based on that.
I see.
And
do
they will
do,
follow up the patient more because they know that the patient has high chance of coming to like acute leukemia again. So they will keep on, like their protocols will be more stringent.
I see. Thank you.
Yeah. Okay. All right. Let's summarize, Nidhi.
Okay, sure. So B lymphoblast. I think so. Again, sorry, I'm like compiling from Brent Wood, and then I think
Yeah,
the
go ahead. That is really good. Go ahead.
yeah. Okay, so the lymphoblasts in BALL, they are always positive for B cell markers, that is CD19, which is the lineage specific marker, cytoplasmic CD79A, and cytoplasmic CD22. Although none of these by itself is specific, their positivity in combination or its high intensity strongly support the diagnosis. So I think that's a really important point. The three important markers, 19, cytoplasmic 79A, and 22. They are like more specific and always positive, though like they should be their positivity should be in high intensity and in combination for the diagnosis. Then lymphoblasts are positive for CD10, surface CD22, 24, PAX5, and TDT in most cases. So most cases CD10, 22, 24, PAX5, and TDT. Then CD20 and 34 are variably expressed, as we saw in our case, and then we read in Brent Wood too. CD45 may be absent, and if present, is nearly always more dimly expressed than on mature B cells. That's what we saw in the graph for the blasts too, that CD45 is dimly expressed to absent. So that was for the B cell markers, then 20 and 34, then CD45. Then next point is about the myeloid associated antigens. Myeloid associated antigens 13 and 33 may be expressed, and the presence of these markers does not exclude the diagnosis of BLL. However, MPO should be negative. And if MPO is positive, either it indicates AML or MPAL. So that's an important point. Okay. And then for tissue diagnosis, WHO says that 79A and PAX5 are more sensitive and specific, and PAX5 is the most specific marker for tissue diagnosis. Then we read that, so we didn't read in detail here, but like B lymphoblast has three lineage, like three stages, like pro-BLL, pre-BLL, pro-BLL, intermediate, and pre. Pro is the early precursors. These express 19, 79A, and 22. And nuclear TDT, but are 10 negative. So 19, 79A, 22 TDT, but 10 negative. Then intermediate stage, so-called common BLL or CALA, they express CD10. Then we have pre-BLL when there is cytoplasmic mu chain expression. Yeah. Okay. Then they try to differentiate it from the hematogons. Hematogons, we saw very beautiful, that waterfall expression of 19, 10, or 2010. So basically there is a continuation of expression of B cell markers, whereas if they are blasts, there would be either overexpression or underexpression of these markers, or there would be asynchronous expression of markers, or there will be an abnormal spectrum. That's what we read for Brent Wood. It's also important because hematogons may be present in post-therapy marrow. So it's important to differentiate those hematogons from the blast. So we read 4 points that Akanksha was pointing to, and we read twice, that CD79 would be increased on blast, CD49F would be increased in blast. So CD9, both ending with 9, that's how I remembered it. CD9 and 49F would be overexpressed in blast, CD81 would be underexpressed on blast, and CD123 would be present in concordance with CD34 on blast. So those were the 4 points that could help in differentiating blast from hematogons. Then just quickly 4 or 5 points for B lymphoblasts with recurrent genetic abnormalities. 2 with genetic abnormalities that express myeloid markers are myeloid markers including 13 and 33. These are translocation 922 and translocation 1221. These 2 B lymphoblastic leukemias, they express myeloid markers. So just 1 or 2 points about everyone. With translocation 922, there is expression of myeloid markers, and it's associated with bad prognosis. Then for KMT2A rearranged or translocation 11q23.3, they are CD10 negative, CD15 positive, and they are positive for CSPGR4, which is basically a NG2 homologue. As Dr. Gupta said, neuroglial 2 homologue that is encoded by CSPGR4 is expressed and is specific for this one. Then 1221, it also expresses myeloid associated antigens. Then we have translocation 514 that is associated with eosinophilia. Next one is translocation 119. Translocation 119, it is associated with loss of CD34. Anything else? I think, yeah, that's a specific one for that. Then with TCR-ABL1 like, for that, we have the CRLF2 increased expression. And then, yeah, and that's it.
Cool, very good. Yeah, so I have meanwhile opened this our non-neoplastic book, and we have I think I showed this earlier, but some of you might not be present in that session. So this type of pattern, you can see this waterfall pattern that is 10 to 20 pattern that is very typical of the hematogones. That's something everyone knows and everyone should always know. Another thing is that, so as I was saying, the early hematogones or early blasts actually. So the hematogones will be losing their TDT. So early hematogones or blasts will be TDT positive, but they will be losing their TDT and gaining their 45. So early on they are dim for 45, they will gain to 45. They will lose 38 as they become more mature. Initial stages will have uniform, like 38 will be there, but the eventual, like the spectrum will be like that of the losing 38 and gaining 45 as we saw over here. And then there is a gain of 22. So 22 is more of the mature marker too. So there will be a gain of 22 in these cases. And 34 is obviously, in obvious reasons, the 34 will be lost. So, and then for 22, there is a dip in 22, and then it becomes higher in case of mature stages. So this is a typical thing that's a typical immunophenotype for the hematogones, and these markers, they can help you distinguish the hematogones from your BALL blasts. And also by morphology, they look different. Like the morphology is kind of smudgy appearance and very blue, purplish cytoplasm. So that when you start seeing your cases, and I mean, I'm sure that many of you are very advanced in your hempath too. So you know that you can sometimes, like, it is evident that those are hematogones. Anything to add, guys? Okay, so let's go ahead. I will try to rush now. So this is here a TALL, and I will just directly go into the immunophenotype. This is 34-1, so it's kind of brighter 45 than your blast gate would be, and it is 34-117 negative, 3 and 7 positive. So 3, we know that it is a lineage specific marker, including cytoplasmic CD3, which is a lineage specific marker here. And then it's 4 and 8 negative, double negativity, and there is a small subset that is 4 and 8 double positive as well. So that's a very good clue that they are double negative blasts. And then CD1A has a variable expression, as we see over here, and so is TDT having a variable expression. So that's a typical TALL for you. And I'll not go in very much detail. It's a 44-year-old man, weight loss, night sweats, fever, and so forth. Prominent anterior mediastinal mass, we read that earlier as well. And this is explaining the same thing that we just saw. So TLL is a neoplasmoblast committed to T lineage that may present as either a lymphoma with tissue infiltration or primary leukemic process. And this is an important point. 80 to 90% of all lymphoblastic leukemias and mediastinum, with the mediastinum, the site of normal T cell development often being involved. And flow cytometry is critical in the diagnosis of disease entity, which accounts for approximately 15% of childhood acute and 25% of adult. And then blast of TLL express T cell markers in association with markers indicating immaturity. Most commonly expressed markers will include 7, cytoplasmic CD3, CD2, CD5 are often positive, can be lost. Surface CD3 often absent. So in that case, there was surface CD3. Surface CD3, as we know, and we saw in the previous maturation charts that we saw earlier as well, that first the cytoplasmic CD3 comes, and then in the more mature stages, the surface CD3 comes. So surface CD3 will be usually negative. CD4, CD8 variably either double positive, double negative, or in rare cases, the single positive cases has been also described, but usually double positive, double negative CD4, CD8. And TDT will be expressed 90% of the cases. CD1A variable and 34 HLA-DR10 may be expressed in some of the cases. Myeloid antigen co-expression in 30% of the cases include 13 most commonly, and 33 and 15 are described as well. Occasionally, expression of 117 or CD79A may be seen. MPO is typically negative. If expressed, should give rise to MPAL, like consideration to MPAL. And because T cell markers described above are also expressed at varying levels in normal maturing T cells, when encountering the specimens from mediastinal region, a thymic tissue or thymoma, we saw a nice case that Raji had of thymic tissue or thymoma, and it's hard to differentiate by flow whether it is just a thymic tissue or it's a thymoma. You have to rely on the morphology. But again, you know that it is coming from thymus based on your typical spectrum that we will see in this one. So recognition of normal patterns of antigen expression seen with TALL maturation is very helpful in distinguishing TALL from thymoma or thymic tissue. In contrast to thymic tissue or thymoma, the immunophenotype type of in ALL deviates from the normal maturation patterns with frequent aberrant loss of the T cell antigens. In addition, in contrast to the variable pattern or smearing of the antigen expression seen in the normal T cell precursors, in the thymus, TLL generally shows tight clusters on dot plots. So you have these maturing precursors that you see over here. And as I said, the surface CD3 is kind of in more mature markers, as a more mature markers. So initially the surface CD3 will be negative, and then there will be a spectrum in the thymus. So like the hematogones, you'll see the smudging or spectrum of the pattern of maturing T cell blasts that you will see and coming to more mature forms. Similarly, as you might or might not remember the figure that we had in our book, but initially those blasts, they are CD4, CD8 positive, and then they become as they mature, they either become 4 and negative. So that's something that you have to remember, this smearing kind of pattern, and again this expression of CD3 and that you will see in the mature forms. As compared to that, in the TALL, there will be a big blob sitting somewhere with high or low expression of things, and it can be 4 or 8 double negative, can be 4 or 8 double positive, and usually 5 is expressed, cytoplasmic CD3 is expressed, surface CD3 can be expressed, but usually negative in many of the cases, and that's the typical TALL for you. So you have to differentiate the thymic tissue from TALL, and that's pretty easy. Sometimes, I mean, unless you're suspecting this, it might be missed, but it's hard to miss this. So several antigenic patterns that appear to carry some prognostic significance has been described in TLL. Occasional cases show aberrant expression of 16 and 56. These cases show co-expression of cytotoxic molecules by HC. This subtype is described in older patients associated with higher presenting platelet counts and shorter disease-free survival. Another subtype characterized, so this ETP-ALL is important now. So ETP-ALL, we know that it should be CD1A negative, CD8 negative, and there should be no CD5. If there is a bright CD5 expression, no or weak. If there is a bright CD5 expression, then you will, and the other features are like ATP-ALL, you're going to call it the near ATP-ALL, and then there will be expression of more myeloid antigens. There will be expression of stem cell antigens. So that's your typical ATP-ALL. And why it is important? I mean, though it is controversial, but it has been shown that this ETP-ALL has a poorer prognosis, and that's why it is important. So this primitive subtype of TALL is associated with poor prognosis as compared to using standard TALL therapy, and it's characterized by weak expression of 5, one or more myeloid or stem cell marker, one or more following on greater than 25% of the blasts. So there will be 34, 117, HLA-DR, myeloid 1333, and 11B and 65. So there will be no CD1A, there will be no CD8. So myeloid and stem cell markers, no 1A, no 8, no 5 or weak 5, all of these are your early T cell precursors. So you can see over here, this one is negative for CD8. There is CD4 expression in the partial subset of the cells. And then CD1A, that is negative. And CD7 is expressed in these cells, and then the myeloid antigens are expressed in variable fashion. The stem cell antigens are expressed in the variable fashion. So and then there is a weak to negative expression of CD5. There is no strong the homogeneous CD5 expression in these cases. So that's your typical ETP-ALL for you. So I'll not read the figure caption because we are kind of rushing now. So similar to BALL, the presence of MRD has clinical significance in TALL, with studies suggesting that peripheral blood may be as useful in monitoring the MRD in TALL as in the marrow. One point to note in evaluating patients for MRD in TALL is that immunophenotype may not be static, with loss of immaturity as associated antigens such as TDT described as early as day 8 post-therapy and continuing to decrease through day 28. So that's an important point. The TDT can be lost post-therapy. And then T lymphoblastic leukemia is a neoplasm of the blast committed to T lineage, and the flow cytometry plays a critical role. And TALL can be distinguished from thymic tissue because blasts deviate from the normal maturation pattern with frequent loss or uniform expression of the antigens variably expressed in that is variably expressed in the thymic tissue. All right. Anyone has any questions or anything to add their experiences? Okay. Nidhi, we can summarize maybe in a couple minutes.
Okay. Please give me a sec. So T lymphoblastic leukemia, as we read, that usually presents with a mediastinal mass, and the cells will have like be positive for T cell lineage markers, which will include cytoplasmic CD3, which is the marker, CD7, CD2, CD2 and 5 are like mostly present, but can be negative too. Then surface CD3 is usually absent. They're usually positive for TDT. CD34, HLA-DR, and CD10. They are like plus minus. Then myeloid markers 13, 33, and 15 can be present in some cases, but they are always negative for MPO. Important differential is thymic tissue or thymoma. Because how we can differentiate from them is thymic tissue or thymoma will show like a spectrum of pattern, a smearing pattern, as we saw in these plots, as compared to TLL, which will have a tight cluster or dot plot, and it would be deviating from the normal smearing pattern. Then sometimes they can show aberrant expression of 16 and 56. There's a subtype which can show aberrant expression of 16 and 56. And then we read about the ETP, that is early T cell precursor lymphomas. So early T cell precursor lymphomas, 3-4 important. Their immunophenotypes is they are CD7 positive. I have like 4-5 points from WHO. CD7 positive. They are negative for CD8 and 1A. It's negative 7 positive, but negative for 1A and CD8. Then 5 is mostly negative or is less than expressed on less than 75% of the cells. Then positive for cytoplasmic CD3, they can express myeloid markers but are MPO negative. So just important points. So 1A and 8 negative and 5 negative or less than 75% of the cells, and positive for CD7. And then can express myeloid markers but MPO negative. And then there is near ETP ALL, which has, so in the ETP ALL, we was negative for CD5 or less than 75% cells express CD5. Near ETP ALL has everything same as I described earlier, but CD5 is brighter or more uniform than the ETP ALL. And why ETP ALL is important? Because it has poorer prognosis. And then we discussed about the that if the minimal residual disease is present, it is a bad prognosis, and TDT can be lost with the therapy. So that's an important point to keep in mind.
Perfect. Okay. So if no one has any other experiences or questions to add, we can go ahead.
Another point I would like to add.
Yeah, please go ahead.
The ETP ALL, like generally the books and articles describe the myeloid and stem cell markers along with the T-cell markers. We had 2 cases which we published in IGLH where even the B-cell markers were there because they are so primitive that they have T as well as B and myeloid cell potential. So even
Right.
CD19, DIM CD19, 79 can actually do in ETP cases. Some of them. So 2 out of our 8 cases had these B markers in addition.
Nice.
Sometimes we are
Thanks.
confused with an MPAL and triphenotype, but they don't qualify for the criteria of that B image.
Right. Yeah, and sometimes this MPAL is a very challenging diagnosis in some cases. Like when do you start calling it mixed lineage or mixed phenotype? It's sometimes hard. Those cases are, I find them especially challenging. Some of those cases, at least.
Yeah, now WHO has very well defined criteria.
Yeah, the WHO
CD19
has very well
strong
defined
with
criteria.
one. If CD19 is weak, then 2 others should be strongly expressed.
They are coming
So
to this
unless that is
discussion.
fulfilled,
They are coming to this discussion. Like we'll be discussing that in the next chapter. All these the WHO's classification system. But sorry to interrupt you. I mean, please go ahead. You want to say that, please.
now the WHO criteria will just want to say that they are very well defined. If one
Right.
follows them well, most of the confusions are avoided.
Right. Yeah. Initially, like early on cases, like initially when that was not very well defined, it was much more challenging. And despite all of these criteria, I mean, to me, sometimes it becomes challenging when to call it MPAL.
Still, there are few cases which are challenging.
Yeah. Okay. So now we already know that we are coming to a case of MPAL. So because I'm rushing, I'll not. Actually, if someone wants to take this.
I can try this. Should I go ahead or someone?
Yes, go ahead, please.
Okay. So we have this lymphoid population, and then in the red we have the blasts. The blasts have like low side scatter and low dim CD45. Then the blasts are CD34 positive, and I'll say like dim CD38 positive. They are positive for CD33, and again heterogeneous expressions for CD117. Then they are also, okay, so they are 33 positive, and then they're also positive for CD2. Don't know, CD3, I'll say like dim positivity for CD3. And then they're positive.
It's negative for CD3.
Okay, then negative for CD3, then positive for CD7, like positive for 56, and then a subset is positive for CD7. Then they are MPO positive, cytoplasmic MPO positive and cytoplasmic CD3 positive. So that gives us the diagnosis.
Right. So that's a very nice one.
Yeah.
So it's MPAL, T myeloid MPAL, and with this cytoplasmic CD3 and cytoplasmic MPO nailing the diagnosis. So I'll just go to the theory. MPAL is a rare subset of acute leukemia, accounting for less than 5% of the newly diagnosed cases. That includes both biphenotypic acute leukemia, in which markers of more than one lineage are expressed on the single blast population. So that's biphenotypic. And then there is a bilineal acute leukemia, in which two distinct blast populations of different lineages are present. So there will be by lineage, that will be two different lineages are present, and there will be two distinct blast populations having two distinct lineages are present. And over here, biphenotypic, and this, for example, is a biphenotypic in which both the phenotypic markers are present in the same blob, in the same single blast population. So although the presence of multiple lineages may suggest may be suggested by morphology, flow cytometry, and plays a critical role in lineage assessment, allowing one to establish this diagnosis. A diagnosis of MPAL can be established in one or three ways. First, if two distinct blast populations are present, one of which would meet immunophenotypic criteria for acute myeloid leukemia, myeloid or monocytic, and other representing abnormal lymphoid blast or bilineal acute leukemia. Second, if there is a single population of the blast meeting the criteria of BALL or TLL with the expression of MPO. In third, if there is a single population of blast meeting the criteria of BLL-TLL with evidence of monocytic differentiation. So these 3 points are important. Of note, expression of markers including 13, 33, 117 is not sufficient. So MPO is the one, and we'll come to the criteria. Myeloid lineage is established by expression of MPO or demonstration of the monocytic lineages, so at least two markers. 11C, 1464 lysozyme or diffuse NSC. So let's directly jump here to WHO classification. So the B cell lineage is determined by a strong CD19. And if there is a strong CD19, then there can be one of the following that can be positive in order to call it B cell lineage positive. So that includes cytoplasmic CD79A, 22, and 10. And then if there is a weak CD19, then two or more of the following should be positive in order to call it B lineage. So those will be cytoplasmic CD79A, 22, and 10. Coming to T lineage, cytoplasmic CD3 is the lineage specific markers or surface CD3. And myeloid lineage, MPO, or else the evidence of monocytic differentiation, that should be two or more of this following. So NSC, 11C, 14, 64, and lysozyme. So that's your typical This is like Dr. Gupta was coming to, that this is very well defined by WHO now. And I mean, to him with having so much of experience, it becomes easy. But to newbies like me, it's sometimes hard. Many times hard. In fact, those cases that we used to have at MSK, like we used to have multiple cases of MPAL at MSK, and some of them they would like say it based on the expression pattern, which I would start thinking that why is this positive, and they would call it positive. It was sometimes challenging for me. So T cell lineage is established by expression of CD3, surface or cytoplasmic. B cell lineage requires either expression of strong CD19 with strong expression of one additional B cell marker, or weak CD19 with two additional B cell markers. Additional B cell markers may include 79A, cytoplasmic 22, and 10. No clear cutoff is specified in WHO classification to determine when to consider a blast positive for lineage specific marker. Although the European Group of Immunological Classification of Acute Leukemia previously recommended a cutoff of 20 for most markers or 10 for MPO. So that was a previous recommendation, but right now there is no recommendation for MPO and CD3. Given the high specificity, this was not adopted for the WHO revision, and ambiguity remains in the application of these criteria in some cases. If a blast population is noted that lacks all the lineage-specific antigens, may be considered as undifferentiated acute leukemia. On the basis of antigen expression, MPAL is then subclassified into B myeloid, NOS, or T myeloid, NOS. Of these categories, the B myeloid is more common in the majority of the reported cases, with rare exceptions in the pediatric populations. So B myeloid is more common. And the most common cytogenetic changes seen in MPAL will be 922 and MLL rearrangements. MPAL harboring one or of these structural genetic abnormalities are classified separately in 2008 WHO classification. MPAL with 922 most commonly has myeloid and B lymphoid component for obvious reasons and should be distinguished from the CML on clinical grounds. MPAL with MLL rearrangements occur most commonly in children and has a myeloid, typically monoblastic component, often associated with B lymphoid blast component that expresses 15 without 10. So MLL has more of monoblastic and B lymphoid that will be expressing 15 and no 10, similar to that with the BALL with MLL rearrangement. And both recurrent cytogenetic changes are associated with poor prognosis. Of note, progenitor cells in some CM, chronic myeloid stem cell neoplasm, and blast in some subtypes of AML characteristically show expression of non-lineage specific antigens. Cases that would be better classified under different WHO recognized subtype would be classified as such rather than MPAL. For instance, 821 will express the B cell antigens, but should not be considered as MPAL. And remember that this B cell antigen, the 19 will be typically dim, weak present. It will not be bright. So that's something that you have to remember. Similarly, in case of 821. Similarly, blast crisis of CML and therapy-related myeloid stem cell neoplasms should not be classified as MPAL. T myeloid, BT MPAL is rarely described. Yeah, we had a few cases of BT MPAL, and however, care should be taken not to overdiagnose this entity, as CD79A and 10 are frequently reported in TLL. Rare cases of trilineage MPAL has been reported as well. Careful immunophenotypic evaluation is critical in establishing the diagnosis of
Okay.
MPAL with accurate
Yeah,
diagnosis. Just a second, let me
Oh,
move
you?
on.
Oh.
So careful immunophenotypic evaluation is critical in establishing a diagnosis of MPAL, with accurate diagnosis being important because some studies show poorer prognosis in adults for this group of acute leukemias as compared to ALL or MAL, and poorer prognosis for children in MPAL compared with ALL. Furthermore, therapeutic approach is genetically driven by lineages represented at diagnosis. Either or both lineages present at diagnosis may be seen at relapse. Okay. So important to look for cytogenetic abnormalities, including 922 and MLL, and cases falling into different WHO categories as 821, or blast crisis of CML should not be classified as MPAL. Okay. I have only 10 more minutes to go with this last case. So we'll quickly go with this last case, and then if I have to go, then we'll finish this, or else Nidhi can summarize both chapters. All right, so this one, we have very nice dim CD45 to negative CD45 population. So we have grands, monocytes, lymphoid, and then this population, which has expression of CD38 and is bright for HLA-DR and is bright for CD123. So we know that those are not basophils based on the bright HLA-DR. The basophils will be over here, dim HLA-DR. So this 1, 2, 3, 4, 5, 6, that is your buzzword for BPDCN. So 123, and then the expression of 4, which over here. So there is this expression of 4, and then the expression of 5, 6. That's your typical BPDCN. There can be expression of CD7 aberrant, and 1464 will be typically negative, and as is 117 and 34. So by definition, 34 and 117, it's not the stem cell markers should not be there. So that's your BPDCN for you. So basically 1, 2, 3, 4, 5, 6, 123, 4, and 56. And then the other markers, including 303 and the other ones, TCL1, are also described are also of importance, and many of the institutes, they perform the TCL1 as well in these cases. So that's something that you should keep in mind as well. So BPDCN is more of the red bumps on the chest, raised non-tender. So basically skin changes, and subsequently on the forehead, back as well. So like more of the bumps or nodules in the skin, that's typical of BPDCN, and then bone marrow biopsy. Okay, so BPDCN, it typically involves skin and frequently involvement of the marrow and occasional involvement of the other organs. Patients usually present in the 6th decade with cutaneous complaints commonly bringing individuals to medical attention. Cytopenias are common with thrombocytopenia predominating. Lineage of of neoplastic cells has been under debate since the detection of this entity, with the uncertainty of lineage reflected in prior names of this for this neoplasm, such as blastic NK cell leukemia and a granular 4 and 556 positive hematodermic neoplasm. We don't need to remember all this. The neoplastic cell is now understood to be of the plasmacytoid dendritic cell precursor, and this entity is now currently classified by AML by acute as a subtype of AML and related precursor neoplasms. The BPDCN typically is characterized by a population of cells with low 45 intermediate site scatter, typically occupying the blast gate, demonstrating co-expression of 456, bright 123, and HLA-DR. These neoplasms will typically lack 34 and DNA-specific or associated markers, including 1923 will be negative, 5 MPO will be negative, 117 will be negative, 1464 will be negative, 16 will be negative. And then neoplastic cells are positive for 43 and may express 7, 33, and 36. 7, 33, and 36 can be aberrantly expressed. Although typically negative, rare cases may express 2 and low 13. TDT is present in approximately 1/3 of the cases, with expression on between 10 to 80% of the abnormal population has been reported. So TDT should not sway you from the diagnosis. If definitive subclassification is difficult by flow, IHC may be helpful because the neoplastic cells will be expressing TCL1 and BDCA2 without lysozyme or myeloperoxidase. So there will be no monocytic like lysozyme or myeloperoxidase. So that will not be present, and there will be TCL1 and BDCA2. Cytotoxic T cell markers, including TIA1 and perforin, are negative, and no reactivity with EBV or EBER is reported. In addition, the neoplastic cells lack MPO and NSC by cytochemical staining. So considerations and differential diagnosis of BPDCN include NK cell neoplasm or acute myeloid leukemia with monocytic differentiation. NK neoplasm are more commonly positive for markers including 2 and 7 and will lack the expression of 4 and 123. Furthermore, NK neoplasms are almost uniformly positive for EBER by NC2 hybridization and typically express cytotoxic markers such as TIA and perforin. Monocytic will be more difficult to distinguish from BPDCN because they have 56, right? So they will be 4 and 56 positive in the monocytic as well. However, 123 will be typically lower in the monocytic leukemia as compared to BPDCN. And definitive separation of these entities is usually possible with careful immunophenotypic evaluation, as monocytic leukemias typically express high levels of 64 by flow and may express lysozyme by HC and NSC by cytochemical staining. So that's how you're going to differentiate. First, the CD123 will be lower dim, and then there will be high expression of 64 and lysozyme by tissue and IHC, and then NSC by cytochemistry. So they have, I wish I want to decrease the size so that it fits into one page. Okay. So they have this nice differentiation between it doesn't fit into one page. Let's see. Okay, it doesn't fit into one page, so there's no point. That's large. Okay, so they have this nice representation of how you're going to differentiate the acute monocytic NK, and BPDCN. So basically the BPDCN, they have shown that it's a bright CD56 population, the aberrant expression of CD7, 123 bright, CD4 bright, and then HLA-DR bright, and with no expression of 64. As compared to that, the acute monocytic has first dim to negative 123, and then it has the acute monocytic will be dim or negative for 56. It will not be having 56 as well. It will be similarly bright HLA-DR. However, the 64 is brighter as compared to over here in the BPDCN. So that's your typical monocytic. And then for the NK, we know that it will be 56 positive. But over here, this 56 is off the chart. It's pretty bright 56 positivity. And then CD123 will be negative in the NK, and HLA-DR will not be bright as compared to the BPDCN. So those are your two differentials that are important. Of note, there is a reported relationship between BPDCN and myeloid stem cell neoplasms, with 10 to 20% of the cases having an associated myeloid stem cell neoplasm noted at presentation. Preceding or occurring subsequent to diagnosis of BPDCN. That's an important point. Let me mute, someone is. So this is an important point, that there can be a secondary myeloid neoplasm that can be associated with a BPDCN, and that should be looked for. And they have shown this example of AMML here. So we can see the population having this blast count, and they typically said that this blast were 23% of the WBC, so it's an acute leukemia. And there was an increase in the monocytes, as you see the pink arrow, and this monocyte was also expressing dim 14 that they have here. So this is actually bright 14. So so there was this acute blast population and the monocyte population that was present, and then this aqua population was their typical PDC population, plasmacytogenetic cell population, and this was bright for HLA-DR. This was positive for CD4. This was positive for 123, but at the same time, this was not blastic plasmacytoid dendritic cell in this case, because this population was lacking CD56, as they have shown in their, like as they have discussed in their discussion. So they are saying that important to note that I'm reading over here. So important to note that expanded population of CD56 negative PDCs can be associated conjunction with the myeloid neoplasm. Therefore, careful analysis should be performed, and they should not be called as BPDCN. So that's what they have shown over here. So BPDCN express 4, 56, bright 123, bright HLA-DR without 3, 5, 34, 117, 64. And with the differential diagnosis, they will be monocytic and NK and T cell, each of which can be excluded by careful immunophenotypic evaluation. If an expanded 56 negative PDC population is noted, careful examination of secondary myeloid stem cell neoplasm is warranted. So that's that. All right. So this is the end of our nice. Okay. So this is the end of our book, and we successfully finished our book. Nidhi can quickly summarize for us before I have to go. Both the chapters, Nidhi, you can go ahead and quickly summarize.
Okay, I'll summarize quickly just with the important points. So first I'll start with MPA, or first I'll start with BPDCN because it's fresh. Okay, so blastic plasmacytoid dendritic cell neoplasms. These are, so I'll go to the immunophenotype. These are positive for, like, as we call it 1, 2, 3, 4, 5, 6. That is positive for 123, 4, CD4, and CD56. And then they are also bright positivity for HLA-DR. So positive for 1, 2, 3, 4, 5, 6, and HLA-DR. They fall in the blast gate, so they have low site scatter and low dim CD45, and they're negative for CD34 and 117. So that's the immunophenotype. And then some other important markers are TCL1 and CD303. CD303, they say, is a very important marker. And so that was the normal, that was the phenotype for BPDCN. Then the important differentials, we have two important differential and then a third condition which we should differentiate. So important differential are NK cell neoplasms. So the NK cells neoplasms, they are because they are also positive for CD56, but the NK cell neoplasms are very bright on CD56 and they're also positive for CD2, CD7 and EBR positivity. However, they would be negative for CD4 and CD123. So basically 1, 2, 3, 4 negative, but they are 56 positive. So that's how we can remember. Then monocytic cells, monocytic neoplasms. So monocytic neoplasms, they are very they are very difficult to differentiate because they're also CD4 positive and they can also show positivity for 56. However, how do we differentiate? So it's based on the spectrum. So they can express some 123, but 123 would be on the lower side. 64, as we know, is a monocytic marker, would be expressed at a very high level in those. And then in conjunction to the flow, we can also do IHC for lysozyme. That would be positive in monocytic. And for cytochemistry, they will be positive for NSC. Then the third condition that we need to differentiate is mature plasmacytoid dendritic cells, which are associated with myeloid or monocytic neoplasms. Those mature plasmacytoid dendritic cells, they are positive for CD4 and 123 and HLA-DR. However, they are negative for CD56 and then so they are negative for 56 if it's mature, not blastic. And then WH also says two other points. They are negative for TDT and they are low on Ki67. So those 3 points can help in differentiation. CD56 negative, TDT negative, and low Ki67. And I think that's all about the BPDCN. And then coming to the MPAL, MPAL could be like biphenotypic or bilineage. So that's important. Then biphenotypic is when one single population of blast cell is a co-expressing antigen of more than one lineage, or bilineage when we have two separate population of blasts. So, and then coming to the, I think most important in MPAL is to make yourself familiar with the criteria. For myeloid, either it could be MPO, by flow, IHC or cytochemistry, or monocytic, in which more than two of the following markers, NSC, 11C, 14, 64, or lysozyme. Then for T cell lineage, bright cytoplasmic CD3 or surface CD3. Then for B cell lineage, strong CD19 with more than one of the following, that is 79A, cytoplasmic CD22 or CD10, or weak CD19 with more than two of the following, 79A, cytoplasmic CD22 or CD10. Then MPAL is mostly like B myeloid or T myeloid, B/myeloid or T/myeloid. And then we have two specific genetic categories in MPAL, that is translocation 922 and then with KMT2A. One or two important points about those. MPAL with translocation 922 is usually B myeloid, sometimes can be T myeloid. But if we see translocation 922, like then we can specifically categorize in this category. Important differential is to rule out CML. If the patient had CML and had gone to blast crisis, then it should be labeled as CML with blast crisis. And this, both of these genetic categories are associated with bad prognosis. Then MPL with KMT2A rearrangement. It is basically B myeloid, but that myeloid component here is usually monocytic or monoblastic, I'll say. And then since it is KMT2A, so the B lymphoblastic population would be 10 negative and 15 positive, as we read earlier in the specific genetic category. And this is also associated with bad prognosis. Then, so, okay. So genetic categories, if we can see those, then put them in those categories, 922 or KMT2A. Not few cases which are not classified as MPAL, like translocation 821, because it also expresses some B lymphoid markers like 19, but 19 would be dim there. And if we are seeing 822, then put it in that category. Then blast crisis of CML. If the patient has a history of CML, it goes into the blast crisis. And rare cases of MPAL could be like, usually it's B myeloid or T myeloid. Rare cases could be B/T or could be trilineage. And that's it.
Perfect. Thank you very much. Good timing. So, all right then. If you have any questions, we can discuss now, or else finish our flow cytometry session. I learned a lot. Thank you very much, everyone, for imparting your knowledge to us. Thank you to Raji. She is not here today, but thank you, everyone. If you have any questions, we can go ahead right now. Otherwise, we can just end up the session.
Thank you to you and Raji. These were great sessions. Learned a lot.
Just to
Akansha,
point out that
thank
this
you very much.
table for B lineage is slightly less stringent as compared to the WHO. If you go there, they would say strong 19 with one or two of the following being strongly expressed, not just expressed. So that
Right.
makes it slightly more stringent.
Perfect. All right, you guys, I'll have to go.
Thank you, Akansha.
Thank you so much. Thank you. Bye.
Thank you. All right. Thank you very much.
Thank you so much. Thank you.
Thank you for joining, Prerna. Thank you. Sagarika, thank you.
Bye-bye. Bye-bye.
Bye.
Thank you,
Bye.
Akansha.
Thank you.
Bye.
Bye.